Thank you, Angel, for leading this very interesting meeting. We are going now to a controversy. We know that there are several trials that have compared dual and triple antiplatelet therapy. Probably most of us have assumed that double therapy is better than triple therapy, but maybe this is not fully true. So we are going to go now to this controversy. The first to participate is Dr. ten Berg from Netherlands, that is going to defend that he prefers dual antiplatelet therapy for most patients. Thank you very much.
Thank you very much for your kind introduction. It's my pleasure to be here, and I was asked to talk about the optimal treatment of patients who have atrial fibrillation and thus need an oral anticoagulant, and are now admitted to the CCU with an acute coronary syndrome or have to undergo PCI and thus need antiplatelet agents. So these are my disclosures. And I'd like to discuss this topic by presenting a case, which is an 85-year-old male, slightly overweighted, as you can see in the picture, who we have known for many years with hypertension, type 2 diabetes, peripheral artery disease, some renal impairment, and he was diagnosed with atrial fibrillation in 2011 when he presented with TIA. At that time, he was treated with VKA, but because of label INRs, he was switched to a NOAC 2 years after. And now he's admitted to the hospital because of heavy chest pain during the night for 40 minutes, classical chest pain. At presentation, he's pain-free, but he has an abnormal ECG as well as positive troponin. So the diagnosis at that time was a non-STEMI, and partly because of a high Gray's risk score, he was scheduled for coronary angiography for the next day. So the first question in such a patient is, how do we treat the non-STEMI in this patient? Do we use dual antiplatelet therapy as we use in all patients who do not have atrial fibrillation and who do not need an oral anticoagulant? Well, this is what the guidelines tell us to do. So in patients who are on an oral anticoagulant, they say that initial dual antiplatelet therapy with aspirin plus a P2Y12 inhibitor before going to the cath lab, so before the coronary angiography, is not recommended, and that's a class 3 level of evidence C. If you read carefully these guidelines, they advise you to use aspirin as monotherapy added to the oral anticoagulant, whether this is VKA or NOAC. We tend to use clopidogrel because it takes some time before clopidogrel kicks in, and probably you need optimal platelet aggregation inhibition at the time when this patient undergoes the intervention. So we start clopidogrel but not use aspirin upfront before going to the cath lab. So the second question in such a patient is, how do you handle the oral anticoagulant? In this case, how do you handle the NOAC? So again, going to the guidelines, what do they recommend? Well, they say that at least you should consider to use uninterrupted therapeutic anticoagulation, whether this is VKA or a NOAC, and that's a class 2A level of evidence C. But you have to remember that probably NOACs are not safe in a cath lab. So if you put a catheter in the patient, you are at risk for catheter thrombosis, and that could lead to myocardial infarction. So whether the patient is on a NOAC or not, you need additional heparin, low dose. In this case, we use unfractionated heparin with a dose of 60 units per kilogram. So how did we treat our patient? As said, we started clopidogrel at the CCU up front. We withheld usually the aspirin. We do continue the NOAC during cath, but we add low-dose heparin. We always perform, as you probably all do, the coronary angiography via the radial artery because it leads to less bleeds. And this patient turned out to have a LAD lesion, as you can see on the picture on the right-hand side. And so before going to PCI, we load the patient with aspirin. So we stented this LAD lesion. There was some impingement of the diagonal branch, so we needed a second stent, but the outcome was successful. So now we have a patient who has been stented, has a high risk for thrombosis, has a Jets VASC of 7, but also has a high bleeding risk, by definition, a has bled of 4. So now probably is the most important point of discussion. What is the optimal antithrombotic regime after stenting? So is this dual therapy or triple therapy? Do we always have to use a NOAC, or is it still VKA? And if you choose a NOAC, is it full dose NOAC, or is it a reduced dose NOAC? Might lead to less bleeds. And if you need an antiplatelet agent, which one do you need? Is it clopidogrel, is it ticagrelor, or maybe only aspirin? So before going into detail about dual therapy versus triple therapy, I'd like to remind you that triple therapy does lead to much more bleeds. These are 2 observations. There are many more observations. On the left-hand side is the Danish National Registry showing that triple therapy even triples the risk for bleeds as compared to monotherapy. On the right-hand side is our WOOS trial showing that triple therapy led to twice as much as bleedings as double therapy. I'll talk to that study later on in detail. And the second point I'd like to make is that most of the bleeds occur in the first, say, 2, maybe 3 months. So the risky period is the first period after PCI. So because of this high risk of bleedings, and as you know, bleeding is not trivial, it is associated with mortality. So because of this high risk of bleedings, we thought to drop aspirin. So we were the first to study double therapy versus triple therapy in the WOOS trial. At that time, we only had VKA, so it's clopidogrel plus VKA versus triple therapy with aspirin. And these are the results. So first of all, the left-hand side you've seen already is the bleeding. There was a drop of more than 50% of any bleeds. And to our surprise, there was no increase of thrombotic events. But I have to state that this is a very small trial. It's only 573 patients. It was not at all powered to look at the thrombotic endpoint. But it set the stage for more trials looking at double therapy versus triple therapy. And the second one was a larger trial, was Pioneer, 2,100 patients, also patients with atrial fibrillation, successful PCI, randomized to 3 groups. I think 2 of them are interesting. And that's the rivaroxaban 50 milligrams combined with clopidogrel, so that's dual therapy compared to triple therapy with VKA. I'll show you the results, quite similar to what we saw in the WOOS trial, a major reduction of bleedings, and again, there was no increase of thrombotic events in the double therapy group. But again, this study, it was larger, it was 2,100 patients as compared to 570 in WOOS, was not powered for the thrombotic endpoint. But there's a third trial, and that's REDUAL. It's even larger than the previous one. It's 2,700 patients. Again, atrial fibrillation, on an oral anticoagulant undergoing successful PCI. Again, randomized to 3 groups, but now it's a NOAC in full dose. So it was the dabigatran 150, the dabigatran 110, combined with clopidogrel most of the time, compared to classical triple therapy with warfarin. And the aspirin was used for 1 month if the patient underwent PCI with a bare metal stent, and for 3 months when the patient underwent PCI with a drug-eluting stent. So what was the outcome? Again, a dramatic reduction of bleeds. On the left-hand side is the dual therapy group with the dabigatran 110. On the right-hand side is the dabigatran 150, both significantly lower in the dual therapy group than the comparator triple therapy. This study has a bigger power for the thrombotic endpoint because the 2 dabigatran groups were put together, the 150 and the 110 groups were put together, and again, there was no increase of thrombotic events in this study. So what do we know so far as an answer to the questions that were raised? I think we can confidently say that dual therapy is safer than triple therapy with VKA. And that holds true for VKA plus clopidogrel. It holds true for the lower dose rivaroxaban plus clopidogrel. And it also holds true for the dabigatran doses, the full doses, 110 and 150 plus clopidogrel. But the question remains, is this positive effect on bleeding, is it due to removal of aspirin, or is it the use of a NOAC? And therefore, there is another trial, and this is the biggest trial. It's probably the best trial that has been done in the field, and that's the Augustus trial. It's 4,600 patients, and it has a 2x2 factorial design. So patients were randomized to a NOAC, that's apixaban, in this study versus VKA. They were initially treated with aspirin, but then they were also randomized to aspirin or placebo. So what was the outcome? This is, again, a bleeding outcome. It's major or clinically relevant non-major bleeding. First is the randomization between apixaban and VKA with a significant reduction of bleeds in favor of apixaban. Numbers needed to treat, 24. This is aspirin versus placebo. Of course, not surprising that placebo does lead to less bleeds than aspirin, and it is a major reduction with number needed to treat of only 14. So if you combine the two, so the apixaban versus VKA and aspirin versus placebo, the worst group in this study was the VKA plus aspirin group, and the best was apixaban plus placebo. So if you compare those, there's a reduction, absolute reduction of 11%, and numbers needed to treat of only 9. So what about the ischemic endpoint in this study? Well, first, it's the comparison between apixaban and VKA. There's not much difference. So the endpoint death, the ischemic events, is quite similar. And there was some reduction in favor of apixaban of stroke, as you can see, 0.6 versus 1.1, but overall, there's not much difference. So what about the ischemic outcomes in the comparison between aspirin and placebo? Again, overall, not much difference, but there is a hint that there is some more myocardial infarction if you drop aspirin, and there's some more stent thrombosis. But the numbers are very small. For instance, stent thrombosis is 0.9 in the placebo group, and it's 0.5 in the aspirin group, so very small numbers. And overall, there is no difference. So the conclusion of this larger trial is in patients with atrial fibrillation and ACS or PCI treated with a P2Y12 inhibitor, apixaban and no aspirin resulted in less bleedings and fewer hospitalizations without significant differences in ischemic events than VKA, aspirin, or both. I'd like to mention a fifth trial. It's not the most important trial. I think it's smaller than the other trials, and it's a repetition of the setup of the previous trials, but it's important because it's the fourth NOAC which was tested, edoxaban, and it is full dose, so 60 milligrams once daily, combined with clopidogrel, and again the comparison with triple therapy with VKA. And just showing you the results, there was a non-inferiority for edoxaban double therapy versus triple therapy for bleeding, and a almost similar outcome of the efficacy endpoint, the thrombotic endpoint. So what is the optimal treatment, antithrombotic treatment after stenting? Well, I'm absolutely convinced, showing you all those data of the 5 trials, that dual therapy is better than triple therapy. I'm also convinced from Augustus, which is the largest trial, that a NOAC is better than VKA. Whether we have to use full dose or lower dose, I'm not sure, but I think there's enough data to say that the full dose is safe, and that comes from REDUAL, Augustus, and also ENTRUST. So what antiplatelet agents do we have to use? There is no randomized comparison, but all trials favored clopidogrel, so about 90% of all patients treated in these trials were using clopidogrel So my personal take is to use clopidogrel, although there is some data, for instance, from Redual, where 12% of the patients were treated with ticagrelor, that it is feasible to use ticagrelor, but only probably in a selected group of patients. So our local practice has been, since 2013, when we finished the WOOS trial, to use dual therapy. So we only use aspirin during the procedure. At that time, it was VKA plus clopidogrel, and nowadays it's full dose NOAC plus clopidogrel. Sorry for the last slide. I leave it with this. Yeah.
Thank you, Jur, for giving your standpoint on this controversial issue. And you explained me yesterday what's the translation from Dutch is for woest.
Yeah.
It's angry.
It's angry, yeah. Aggressive,
so we expect an
yeah.
angry debate now.
Yeah.
And we will have time at the end to answer more questions. And you can defend your standpoints then. I would like to continue now, and it's a pleasure for me to announce Professor Marino from the University Hospital of Murcia, and he will give his standpoint on the triple approach.
Okay, thank you. Thank you for the invitation. Congrats for this excellent presentation. These are my conflict of interest. I think we are very focused in the bleeding risk, use the radial access, select the best antithrombotic therapy. We are using vitamin K antagonists. We have to improve the quality of our anticoagulation with a high TTR. We are prone to use the drugs, and of course using gastric protection. But unfortunately, this is a very complex situation. It's not only important the bleeding risk. It's very important what is the clinical setting, acute coronary syndrome, or elective PCI. We have to prevent stent thrombosis, to prevent problem in the future with the target vessel evascularization. Of course, what is the risk of embolism? So we will look for the best antithrombotic therapy in every patient. Indeed, bleeding is important because the majority of patients with myocardial infarction that suffer a major bleeding will reduce or discontinue the antithrombotic therapy. And this is associated with the risk of MACE in the future. But our patients are very high risk patients. This is in an old publication of our group. They are elderly people with many comorbidities, renal dysfunction. So they are at risk of complication in the future. And unfortunately, all our patients are, we can identify all these markers that they are related to the high bleeding, the high bleeding risk in the future. The WOS trial, this is probably a very, very famous trial. Indeed, there are reduction in the main objective, but based mainly in TIMI minimal and minor bleeding complication. And perhaps surprising, reduction in death, and even a trend reduction in the stroke. But probably this is related to the problem with bleeding complication and discontinue the antithrombotic therapy. We know the different limitation of the worst. Of course, the limited sample size, and a small proportion of patients with acute coronary syndrome, the use of femoral access. It's perhaps surprising how to use triple therapy for 1 year in patients with chronic coronary syndrome, low use of PPI, so different limitation. Indeed, we have no robust evidence, and this is the reason the heterogeneity in the recommendation of the different European guidelines. But it had been changing in the last documents. For example, the consensus document of the ERA with other societies that I may remember that Professor Tember is one of the collaborators of this document published in Europe last year. But the controversy is to use in most of the patients triple therapy, even short, in a short period, or like the American recommends the default strategy to use dual therapy in most of the patients. In my opinion, it's not a controversial against European and Americans, because the same Americans, a few years ago, they also recommend in most of the patients triple therapy, short period of triple therapy, and after this recommendation, only the trials with DOACs has been published. These different trials, they are not homogeneous, of course. The limitation of comparison between DOAC and vitamin K antagonist, 12 months, 6 months. But in my opinion, in all those trials, the initial management was usual. And initial triple therapy was offered in all cases, from 5 days to 14 days before randomization. So in my opinion, the controversy is not to use or not to use, because all of them were used triple therapy, and we have to discuss what is the period for the we should stop this triple therapy. Very, very important is the clinical situation about this. This is an elective, or we are under acute coronary syndrome, and even the American and the European guidelines, they are discussing what to do in this different clinical situation. Indeed, there is no clear if we use a very short period of triple therapy, if there is an increment in the bleeding risk. There are many papers from the Danish cohort. This is one of them. Dual therapy and triple therapy increment the risk of bleeding, but in this paper there were no differences in non-fatal and fatal bleeding, and of course no differences in all-cause mortality. What about the result of the DOACs trial? Indeed, they are under power for finding differences in the thrombotic complication, myocardial infarction, stent thrombosis. But there are some clues that there may be an increment in the stent thrombosis and in MACE in this study. For example, this is a subgroup of patients of the Pioneer, and we could see a trend in the increment in this thrombotic complication. In the study of the Redual, we may also find a trend in the increment of this severe complication. And also in the Augustus, this is important to look for the comparison between aspirin and placebo. Most of the stent thrombosis happened during the first month. And this is a small proportion, but there is a clear increment in the risk of stent thrombosis in the arm of placebo. So different meta-analyses have been published. This is one of them by the group of Filippo Crea. They found that in these elder people, atrial fibrillation in many patients, we should undergo complex coronary intervention, and see the significant increment in the rate of stent thrombosis with dual antithrombotic therapy. So the author recommends the use triple therapy in most of the patients, and only in patients with very, very high bleeding risk, we should use the dual therapy. Another meta-analysis by Tanya Popara or Gregory Lipp, they also found this increase in the risk of myocardial infarction and thrombosis. And they also recommend the triple therapy in most of the patients, and of course with a short period of this triple therapy. And the recent published meta-analysis published in European Heart Journal last December, they also confirmed the reduction in bleeding risk with no differences in all-cause mortality and cardiovascular mortality, but again with an increase in myocardial infarction and stent thrombosis. So this is the take-home figure in the same paper. Indeed, this is a change of the paradigm, because we are the last trial, we are trying to look for the reduction in recurrent ischemic events without increasing bleeding complication. They are most of the trials. And now we are trying to only to reduce the bleeding risk. This is a completely change. So, in my opinion, on different variables, the clinical context, the patient and PCI characteristics, the use of different antithrombotic therapy, we should look for the dose and the duration of this antithrombotic drug for every patient. Thank you very much.
Thank you very much, Francisco. I think you both come here. I think we have, Angel, some minutes for questions, for discussion. Some questions from the audience? There is a réplica. Okay.
Yeah. So could you put up the slides again? You just saw this guy on the left-hand side, and I've met before, and this is a very nice, very honest guy, and he's usually very timid. But I also know when he takes off his glasses and he uses some hair cream, he turns out to be a totally other figure on the right-hand side. So it's not the one on the left-hand side, but it's the one on the right-hand side who promotes triple therapy. And that's obvious. He loves bleedings. And I warn you not to follow this guy, because if we are going to treat all our patients with triple therapy, it's going to be a bloody mess. And that's not what we want. Guys like him tell us it's only a very short period of time with triple therapy, so it's safe. And, well, he's probably right, because stent thrombosis does occur in the first months. Well, the highest risk is in the first months. And triple therapy does prevent stent thrombosis. What he doesn't tell you is that the incidence of stent thrombosis is very, very low nowadays. It used to be a couple of %. It was related to mortality, but nowadays, as you've seen in the Augustus trial, it's only 0.9% in the placebo group, and it's 0.5% in the aspirin group. So it's very difficult to reduce stent thrombosis with aspirin, and probably it's not as important as bleedings. What he also doesn't tell you is that the bleeding risk is highest in the same short period of time with triple therapy. And bleeding is very, very high. It's still very, very high. It hasn't decreased over time. I'll show you just two of the studies I just mentioned. On the left-hand side is the Augustus, on the right-hand side is the Redual trials, the two biggest, the most important trials. And major bleeding and clinically relevant non-major bleeding is over 10% in the first months. So it's still very high. And in these trials, even the patients with the highest risks were not included. So the patients with previous bleeding, previous surgery, diminished renal failure were not included. So probably in daily life, the risk of bleeding is even higher than depicted on these slides. So this guy on the right-hand side favors the European guidelines. But we have to notice that in these guidelines, were not the data from REDUAL, not of the Augustus, and not of Entrust. And I hope that Marco and his friends will be smart enough to change the guidelines when the new version comes up. I think the Americans are smarter than the Europeans. They have changed their guidelines already. As my opponent said, they use triple therapy. That's true. That's also what we use. We use aspirin in the cath lab. I think it's wise to use it in the cath lab, but as short as possible. So we use it only one dose. You have the advantage of the kicking in action for about 7 days, but we drop it immediately. And maybe you can use it for a couple of days until you discharge the patient, but the message is, if you use aspirin, use it as short as possible. And that's also in this position paper. So they use triple therapy, PCI, but then they drop aspirin and use dual therapy for 12 months. And I think that's the way to go. You've seen this meta-analysis, just mentioning it shortly. It definitely shows that there is a reduction of bleeding. There was also a reduction of major bleeding, for instance, in REDUAL, in favor of double therapy. There's no increase of death if you drop aspirin, and there is also no increase of major adverse cardiovascular events in the bottom of the slide. But there is, I've said it before, there is a hint that there is some more myocardial infarction and there's some more stent thrombosis if you drop aspirin. But look again at the numbers. It is very, very low. The largest difference in stent thrombosis is in the REDUAL trial, at the bottom of the slide. It's only 22 events in the dual therapy group and 8 events in the triple therapy group. And if we go into detail in the trial, where do they come from? It's not with the higher dose, the bigatron. On the right-hand side, you can see that the comparison between the bigatron double therapy 150 and so warfarin triple therapy, there's no difference at all. There's no difference in stent thrombosis, 7 versus 7. There is the myocardial infarction is almost the same. The difference is in the lower dose. So if you use a lower dose of a NOAC, it might be that you do need aspirin. But again, there's no significant difference. It's only numerically higher with stent thrombosis in 15 in the one group and 8 in the other group. So probably it's not worth using aspirin in all these patients, but maybe in a very small group. So we will not change our local practice. I told you we've been using double therapy in all our patients since 2013. At that time, it was VKA. Nowadays, it's NOAC, and it's going to stay the same, whatever my opponent tells you.
Thank you.
I'll send you the slide, the first one.
Of course, bleeding is important, and there are many actions to try to reduce the risk of bleeding in our patient, because if our patient bleeds, we will be in problem, of course. But these are elderly people with diabetes, renal dysfunction, so the coronary arteries we will find they are quite complex. In this study, selecting or exploring the patient with complex PCI, upper than 3 lesions treated, bifurcation, like the patient you presented before, with 2 stents implanted, long length upper than 60 millimeters, or treating chronic total occlusion. Patient with this complex PCI will suffer more events than people without this complex situation. And the magnitude of the benefit with the long-term dual antiplatelet therapy was possibly greater per increase in procedural complexity. And this long term, of course, was associated with the risk of major bleeding, but was similar between groups. But I'm saying if we have patients with a complex situation, it's needed in these patients to prolong the dual antibiotic therapy and, of course, the triple therapy. This very nice table, in my opinion, is the first occasion that the table like this was found. We can find that the patient that probably will benefit of using triple therapy. What is the type of patient with previous thrombosis, or even with adequate antibiotic therapy, stenting, or the last remaining patent coronary artery, multi-vessel disease in diabetic patients, chronic kidney disease. This is the list of situation. And in my opinion, using dual therapy in this type of patient, for me, is quite dangerous. I want to finish with this paper in Harvard, David Capodano, and I completely agree with his saying in this paper. Triple therapy is recommended for patients with AF presenting with PCI or acute coronary syndrome. And in the guidelines from Europe, there is a consensus that it should be as short as possible and should be avoided only in those patients that concern the bleeding who prevails over the concern of ischemic complication. The rationale that you are saying that less is more combination, dual antithrombotic therapy, are also effective, remains as a matter of uncertainty due to the small size of the available study, and we are not confident what happened with the thrombotic complication. Probably the patient-by-patient decision after characterization of the individual bleeding and ischemic risk profile is the best strategy to achieve a net benefit in efficacy and safety. Thank you very much.
I think now we have some minutes for discussions with the audience, and I don't know if there is some questions. If not, on the meanwhile, one concern we may have is patients with STEMI, because only about 10% of patients included in these trials had STEMI. What happens with these patients? Should we prolong the 1 or 2 days aspirin therapy to a couple of weeks, or still, what their opinion for both of you?
Well, I'm not sure. We never use aspirin, as I said. So also in patients who come into the hospital with STEMI, they're loaded, of course, in the ambulance with aspirin, but we drop it immediately. So, but that's only observational. There are sub-analyses, for instance, in REDUAL. So that's ACS versus stable coronary disease undergoing PCI. There was no difference. So there was no interaction between triple therapy and the condition, whether it was ACS or stable coronary disease. So I don't think there's much evidence, although you would say it is the patient group which has the highest thrombotic burden and should treat with triple therapy. I don't think there's much evidence in the literature to say that those patients should be on triple therapy longer than only during the procedure.
I think there are some questions from the audience. Daniel? Please go ahead. Yeah. Sorry. You are the first here who has the microphone.
Okay. Thank you very much. Just to comment, I don't perceive that much of a difference between the European and the American guidelines. To me, it's a matter of the glass is half full or half empty, because you can look at it from one side, making one the default strategy and saying, well, if there's certain criteria, and then you deviate from the default strategy, and the other way around. So I think even you would agree that there are some patients that do better with triple therapy, and you said there's a lot of patients who do better with dual therapy, and I think clinical judgment is still necessary.
I fully agree, but I think the problem is that many of those patients who have a high thrombotic risk, the ones who have diffuse disease, many stents, etc., are also the ones who have the high bleeding risk. And that puts you into troubles when to decide whether this patient needs triple therapy or double therapy. So what prefers in such a patient? And I would say that bleeding is much more important than this very small incidence of stent thrombosis. So if this patient has a higher bleeding risk, I would always use double therapy and not triple therapy.
So very nice, I'm here. So very nice lectures, great arguments. Daniel Ardi from Hungary. Irian, your arguments are great, and I fully agree that we should use as short as possible aspirin treatment in such indications. But sometimes I feel that this is a confusion of dropping aspirin immediately, because in the trials, the average day of randomization from PCI was like 5 to 6 days. So it's not an immediate drop after PCI, but at least some days on aspirin. So do you agree on that? And if you follow the Kaplan curves in Augustus, the first days are still, they are superimposed and they are trying to diverge after some days. So in our centers, we feel confident of 1 or 2 weeks of aspirin because we still have some benefit according to the stent thrombosis hypothesis without bleeding risk. So do you agree on that? So not immediately dropping aspirin or some days, or you have another perspective?
Well, that's what we do. It's our local policy to drop it almost immediately. And it seems to work. That's the only thing I can say about it. And I can imagine that you use it a little bit longer, a couple of days, but the warning is, again, that the bleeding is very high in the beginning. So also in the first 2 weeks. So if you continue aspirin in the first 2 weeks, you also get the bleeding risk, which is very high at that period. So personally, I wouldn't go for 2 weeks. I would go maybe for a couple of days.
And just one short question. We had high expectations to reduce mortality after WOOST. So why don't we have any signal on mortality now with the NOAC trials of dropping aspirin with these large reductions in bleeding?
Yeah. I think we were just lucky in WOOST. It is not a good explanation why there was a reduction of mortality and thrombotic events. It might be, as you said, if the patients bleed and they drop the antiplatelet agents, you get more thrombotic risk. But I'm not sure that that is the mechanism in WOOST. It was too small to look at mortality. It is disappointing that there is no hint of mortality reduction, while there is still a large reduction also of major bleeding. For instance, in Redual, there's a reduction, significant reduction of TIMI major bleeding, and those are big bleeds. It might be that the incidence is still too small to see a hint of reduction of mortality, but I'm not sure whether that's the explanation.
I have a question.
One remaining question.
In our hospital, we also dropped the aspirin as soon as possible, also with good results. The only concern is, are you not concerned about the people who are clopidogrel non-responders, that you then only are treating after an infarction with a NOAC?
Yeah. So in those patients, we use ticagrelor. I didn't mention it in the talk, but there are some observational data, also the sub-analyses from Redual, which look fine for ticagrelor. And patients, for instance, with the STEMI, I just mentioned, are loaded in the ambulance with aspirin and ticagrelor. So we drop the aspirin and we continue the ticagrelor in those patients, unless the patient has a very high bleeding risk. The very elderly, etc., the ones who had the bleeding before, or renal insufficiency, we switch those to clopidogrel.
But you don't standard test all your patients, right?
Well, we use to test all those patients, yes, but that's in research, but not in daily practice.
Just a comment. I think we have to agree that we have no data. When can we stop aspirin? It's just gut feeling. In one institution, maybe it's safe to do it this way, in others not. So it's gut feeling, we don't have any data. But we have data on the comparison between the lethality with stent thrombosis and with bleeding. And there is no match between them. Stent thrombosis is a killer. So we have a mortality between 10 and 50%, 10% in distal branches, 50% probably in the LAD or in patients with severely depressed ejection fraction. And bleeding, even intracranial bleeding, is about 10-folds less lethal than stent thrombosis. That's a fact. That's why the neurologists actually advocate to restart NOAC even after intracranial hemorrhage. And we are now randomizing patients between LA occlusion and restarting NOAC after first intracranial hemorrhage. So you can't compare them. That's why it may be practical to start for a month with a triple, and if the patient bleeds, you can stop it. But why should you remove this very safe protection mechanism against a killer like stent thrombosis?
Well, I would say that the oral anticoagulant is sufficient to prevent stroke. That's one. Two, maybe one antiplatelet agent is enough to prevent stent thrombosis if you combine it with an oral anticoagulant. So who tells you that you need triple therapy? What is the additional value of aspirin when you are on a P2Y12 inhibition and a thrombin inhibitor by the oral anticoagulant? I'm not sure that you need aspirin. And there are other observations, for instance, in ACS, we've recently seen that the 3 months of depth is enough, and you can be on monotherapy of P2Y12 inhibition.
Oh.
I have a comment with regards to your concern. One of the main criticisms about these trials is that they are underpowered for certain endpoints like thrombosis, but I don't think it's not ethical to put hundreds of patients in major bleeding just to demonstrate that a dozen of patients or less have thrombosis. I mean that there is a dilemma between the clinical relevance and the statistical signification. I think we cannot design a trial with 10,000 patients just to see if thrombosis is definitely significantly lower with triple, when we are in the other side of the slide watching that there are 15 or to 20% absolute number less of major bleeding. It's not ethical because the patients, they don't want to have thrombosis, but they don't want to go to the hospital with bleeding. And bleeding has a mortality that is equivalent to an ST elevation MI when it's Barg 3, 4, 5. And stent thrombosis is less and less common because we have better and better stents. I do remember when we have the 12 months dogma for the APT, and was for many years going on. And all the people saying, well, it's impossible to decrease the APT in drug-eluting stents less than 12 months. It's very dangerous. And now we are giving 1 month. Stopped up 2 trials, smart choice trials. Many trials demonstrate that we can put drug-eluting stents, implant drug-eluting stents with just only 1 month the APT. Then I think the dogma of triple therapy comes from dogma. It's not a trial. There is no trial in the past demonstrating that triple therapy was good. It was empirical. Let's put together the treatment for AFib and the treatment for stents. It's very simple. Then triple therapy, but the evidence is in favor of double therapy. If we do put patients in triple therapies because we have to make exceptions, I agree with you. Very complex PCI, very low bleeding risks, but the only evidence we have is these trials. Before these trials, triple therapy was just used because it was empirically thought that we have to combine the treatment for atrial fibrillation and stents. But the interplay between the treatments is dangerous for many patients, I think, and even more that we are treating more old patients, and they are in higher risk of bleeding.
In my opinion, it's a very easy conclusion. For me, it's not so easy because there are many complex lesions with calcium. In some patients, it's difficult to implant to get the stent implantation perfect. So, like I'm seeing, is not is to maintain the aspirin for 2 weeks, perhaps. Because in the trials, we have not all the clinical situation we are seeing in the real life. So the same we are performing in the trials to maintain the triple therapy for near to 2 weeks. Perhaps the best option is to go on in these special patients for 2 weeks, 4 weeks more, seems logical.
One last comment by Lina before the coffee break.
Oh, thank you. Thank you to you two for this very heated discussion. I have to say, though, that the reason why aspirin was given it was not empirical. It was data showing that in patients with thrombosis and treated with angioplasty, they had to be treated by an antiplatelet and aspirin. And why aspirin? We are forgetting that aspirin is anti-inflammatory. No, the triple is afterwards, but I'm meaning that the association of both AF and coronary disease was coming from knowledge in the area of coronary disease. Aspirin was needed because when you are doing an angioplasty, you have a plaque that is active and it has inflammation. We know by other trials that inflammation as a target is important. So I think what is happening here is that we don't have enough data yet, and we need more analysis of patients that maybe are not, the patients that are in the trials that are very well selected, patients, as you said, that are very complicated, that have an inflammatory readout. And you have to see that in the meta-analysis you showed, what are the two readouts that were worse for double therapy? Myocardial infarction and stent thrombosis. Both have inflammation. The two that have inflammation. If you leave the patients without aspirin in the phase where there is an inflammatory reaction to your procedure, you can have a risk. And if you think that you are going to extrapolate your message to all the patients that are being treated around the world, it's a little bit complicated because obese have chronic inflammation, subclinical. Diabetic patients have subclinical inflammation. So there are many considerations that are important. So we should be cautious. And as you said before, I think it depends on the patient possibly. So the message should be careful, not to say we don't need aspirin. We don't have the data yet to show that. Because in the acute phase, you have inflammation. And instead of giving a very expensive drug, you can give aspirin. And aspirin is blocking inflammatory reaction. Partially, not as much as a blocker of interleukin, obviously, but it's also an anti-inflammatory drug. And that's what I think is missing in the discussions usually, because people think that you use aspirin to block thromboxane, but there are other actions of aspirin.
Okay. But then in practice, you would prefer to keep aspirin for long duration. I mean, if you want to inhibit inflammation, it would be 2 weeks enough, or is it long term?
Well, it depends. This is another question that is pending. But it's true that when you open a vessel, in the 2 months or 1 month after, you have cytokine levels high in blood. These were studies done 10 or 15 years ago when angioplasty was used and stents replaced the angioplasty. So you have readouts in blood of some cytokines that are at higher levels. So meaning that when you are opening a vessel or you're putting a stent, you are doing some effect on the wall, the vessel wall, that is producing an inflammatory reaction. And possibly this should not be very long. But the reaction of this inflammatory reaction will depend on the patient, like was described. So a clinical eye is important where you recommend one or another, because this reaction might be important in some patients. And the fact that you have myocardial infarction and stent thrombosis that read out, both have a component of inflammation there. So this is something that is few patients, very small numbers, but maybe we have to have some time aspirin. I don't know how long. Short.
I think we have to continue the discussion in the coffee break now because we are over time.
That's a pity.
So you see the discussion is very controversial, as this is also reflected by the different interpretation of the results by the guidelines, I think. So thank you very much for the excellent presentations, for my co-chair. And watch out the vampire.